Okay, good afternoon, everybody. I propose we get started. Welcome, everybody, to the official launch of PsyPal. My name is Joost Breeksema. I'm the Executive Director of the Open Foundation, Netherlands-based public benefit organization, an independent knowledge sharing and networking organization dedicated to advancing research into safe and beneficial therapeutic applications of psychedelics. I'll be your moderator today, my organization, Open, is also one of the partnering organizations within PsyPal. So this event is hosted by MEP Cyrus Engerer from the SND, who unfortunately could not be with us in person here today. And it's jointly held by the MEP Interest Group of Brain Health and Neurological Conditions, which is provided by EFNA, the European Federation of Neurological Associations, together with the MEP Action Group for the Medical Use of Psychedelics, which is hosted by Parea, Tadeusz Haubrot, sitting next to me. So just so you know, this meeting will be recorded, and we're joined by an online audience as well as everybody who's here in person with us. And this meeting is organized at a special time, as we are in the very last days of the MEP in session before the Parliament closes for the European elections, which are held 6 to 9 June. It's hard to miss if you're here in Brussels. And it's not only a special time, it also marks a special occasion, as the launch of PsyPal is the very first time ever that the European Union, through Horizon Europe, is funding clinical research into psychedelics. And PsyPal is also a pioneering initiative. It addresses critical gaps in palliative care by examining how psilocybin-assisted therapy might relieve the psychological and existential distress in patients suffering from progressive diseases, using altered states of consciousness as a therapeutic tool. So today we'll look at some of the scientific underpinnings of this approach, the role of patients, the legal and regulatory landscapes of psychedelic research in the European Union, and we'll explore the potential impact of these treatments in the future of mental health. Our next speaker, my neighbor, will go into more detail about the trial itself, but I think it's worth mentioning here and emphasizing really the pan-European scope of this trial. We have 19 partners from across Europe, 9 different member states, from the Netherlands to Sweden, from Portugal to Czechia. It's really a multidisciplinary, multinational effort. And finally, before I give the floor to Professor Robert Schroevers, I want to emphasize the importance of the cross-party support we have in organizing this meeting, which includes some of the most important parties in the European Parliament, the European People's Party, the Progressive Alliance of Socialists and Democrats, and the Greens European Free Alliance. Okay, without further ado, I give the floor to my distinguished colleague, Robert Schroevers.
Thank you very much. Good afternoon, everybody. We are very happy, first of all, that we can present this project because the EU Horizon program has funded it, which, as the chair of this session has just said, is a really a landmark in the development of psychedelic treatments for mental issues. I will briefly discuss the PsyPal project, but before I do that, I will talk a little bit about the breadth and impact of mental disorders. Can I go to the next slide? Thank you. So brain disorders, and phrased as the combination of neurological and mental disorders, are the first cause of disability-adjusted life years. So that's a measure of disease impact. It's a very important cause of death for a range of reasons. In the EU, nearly 200 million Europeans, these data are from several years back, so it will likely be around that number, at this point, live with brain disorders. That includes one out of 3 in the total lifespan, and treatment for these disorders accounts for over a third of Europe's total disease burden. So this really has a huge impact on individual lives, but also on society. The yearly costs, the yearly societal costs are also staggering, and they are not only direct costs, but also indirect costs. So, for example, loss of productivity, the impact on families, the impact on social relations, all of that is impactful. And even though a lot is being done, also on the EU level, you could say that there still is some lack of awareness, although but I would rather rephrase it. There's a growing awareness of the pervasiveness of these disorders. Next slide, please. And why are they so pervasive? This is a slide that I often show, which is from population studies, and it shows on the horizontal axis, you see the age span, and then you see the incidence of diseases that have often a chronic course that influence disability. And as we all know, most diseases start at a later age in life. And there's one big exception and one very influential exception to that, that is mental disorders. The peak of the incidence is between 15 and 25 years. And if it doesn't get treated adequately at that stage, there is lifelong impact. And that also goes for some of the neurological disorders. So that shows also on a life perspective what we are talking about. Next slide, please. And treatment resistance is a major issue in, of course, the whole of medicine. We would like to be able to cure everybody, but we can't. But definitely also in psychiatry, we have a lot of effective treatments, but still about 30% of our patients across conditions is not helped by the treatments that we currently have. So there is a huge unmet need. Next slide, please. And this is why the EU is more and more recognizing the importance. And the next slide. Relatively recently, there is growing interest in the potential of psychedelics to treat mental conditions and also some neurological conditions. Studies are now showing beneficial results of, for example, psilocybin in depressive disorder, treatment-resistant depression, MDMA in PTSS, and a whole range of compounds that are being studied for different conditions. And ketamine, which is not a classic psychedelic, is now registered for treatment-resistant depression in many countries, which already is a major step if you compare it to the antidepressants that we currently have or that we had before that was a possibility. Please, the next slide. Studies are now being done in depression, in PTSD, in substance use disorder, and also pilot studies, smaller studies are exploring the potential in conditions such as severe eating disorders, anorexia, obsessive compulsive disorders, neurological neuropathic pain syndromes, which can be very hard to treat, and lastly, end-of-life distress, which is the focus of this project. Because being confronted with a medical illness incurs psychological and existential distress. people are faced with realities that they have to cope with, the reality that they will not be cured, the reality that their functioning will be influenced, and that this is permanent and that it may become worse, and even that death is somewhere on the horizon. And this may cause depression and anxiety symptoms, and it may definitely affect how people cope with these realities, whether they're able to grieve, whether they're able to share with family and others what this means for the time they still have remaining. And it also affects the course of the medical illness. So there's a whole range of reasons why such a condition is relevant both for the patient and also for the people around that patient. Unfortunately, the current treatments that we have are not shown to be very effective for these psychological problems. And also people may not have a very long time, and they are also physically challenged by their physical illness. So there would be a need for treatments that would be effective and that could deliver that effect in a relatively short time. Okay. And this is why we are going to do a large, in the field, multi-site, double-blind, placebo-controlled trial in which we are going to investigate end-of-life distress, but we will operationalize it as people having above threshold number of depressive symptoms. And we will do this trial in patients from 4 categories of physical illnesses. The first are chronic obstructive pulmonary disorder, so COPD, which will be studied in the Groningen, in the Netherlands site. And then ALS, so amyotrophic lateral sclerosis, patients will be treated in Copenhagen. Multiple sclerosis will be the specialty of the site in Prague, and atypical Parkinson's disorder in Lisbon, in Portugal. And in this trial, we will determine whether psilocybin versus an active placebo, so 1 milligram psilocybin versus 15 and then 25 milligrams of psilocybin, is effective in relieving depressive symptomatology. And we will also study whether these effects would differentially be differential depending on the medical condition of the patients included. We can go to the next slide. And this is a bit a complicated picture, but the design is that after patients are included, they have a number of preparatory sessions. So one thing we know is that for psychedelic treatments to be maximally effective, patients have to develop a trusting relationship with a therapist because they need to feel comfortable. They need to feel well taken care of, well guarded during the session. And also the themes that come up during the psychedelic sessions are things that people would want to discuss in psychotherapeutic talks afterwards, which is what we call integration after the session. So people will be 2/3 of the patients that are randomized will be offered 2 sessions of psilocybin in increasing dose. And then after the first phase, which is the classic randomized clinical trial phase, those who have had the placebo condition will also be offered the a psilocybin session open label, which we think ethically is really important, because that way, if you take the trouble of participating, you will be able to experience whether this is helpful for you. And then in the second phase of the study, because we do not only want to look at primary efficacy, in the second phase of the study, we will look how people fare afterwards. So there is a longer follow-up phase in which people will receive support. There will be an online environment, but there will also be peer groups, and people will be followed also to see whether, if they improve initially, whether they are able to maintain this improvement, whether it really affects the way they can lead their life with the restraints of that their life has due to their medical illness. So this trial, and that's one of the reasons why we are with so many organizations. There's organizations focusing on spiritual care. There's organizations that focus on how to build such a platform, how to organize peer support, and a whole range of other subjects. I think we can go to the next slide. This is the treatment format that we use. So there's 3 preparatory sessions, then there's the dosing sessions, then there's integrating sessions after the first and after the second dosing. And we believe that with that, we found sort of a balance between what patients will be able to sustain in terms of the energy they have, and also what would be needed to have an optimal psychological process. And the follow-up, so the non-dosing sessions, if needed, can also be offered online to optimize comfort for patients. Next slide, please. Yeah, this is, so we will focus on mental problems, as I was saying, depressive symptoms, but also we will look at other concepts of the end-of-life distress phenomenon I was describing, because depression is a classification that we know, but depression is heterogeneous. And we also are going to look at demoralization, death anxiety, end-of-life distress, quality of life, because we want to fully capture both the psychological distress before this treatment and also whether this changes and what changes. And we do that not only with structured measurement instruments, but also with qualitative research. And apart from that, we are going to look at more neurobiological aspects to see what mechanisms are affected by these treatments, and whether in the long run we may look at predictors or mediators of outcome. Then we have the follow-up, and then I think you can go to the next slide. The continued care and public involvement I already mentioned, so we can go to the next slide, which is I think what the take home from this slide is we are now in this year we are preparing everything so that the trial protocol can be evaluated by the CTIS, so the new European Medical Ethical Procedure. Our aim is to start including patients on the 1st of January 25, and then we have 2 years for inclusions and treatments. And after that, we will start analyzing the results and work on the descriptions, articles, deliverables, all of that. It's quite a lively process with a lot of groups, and we are already working very hard to meet all the deliverables and obligations that we agreed on. And these are the partners. I don't think I'm going to read them all to you, but as you can see, it involves both clinical, academic, but also patient organizations, and also organizations that look at public, the PPI, so the public and patient involvement, and how we translate and how we share knowledge with all the different beneficiaries of this project. That was it. Thank you very much.
Thank you very much, Robert. I just realized I forgot to properly introduce you. So this is Robert Schroevers, the principal investigator of the study, professor of psychiatry and head of the Department of Psychiatry at the University Medical Center in Groningen. So that's him. I would also like to acknowledge and welcome MEP from Czechia, MEP Radka Maxová. Welcome. Thank you very much for being here. Feel free to ask any questions or intervene if you have something to ask or add. We have time for 2 or 3 questions. We have some questions from the online audience. I'll read one question, and then if we have additional questions from here, please let me know. I have a question from Petr Šupa. He said, regarding the collected data from participants, with the first one being at the start and then 6 weeks gap, don't you think you're losing lots of valuable dynamics in this period? And do you plan to utilize experienced sampling methods or any other feasible wearable technologies to collect moment-to-moment data?
Yeah, I think that's a very good suggestion. We are looking at that. One thing you should keep in mind is that we need to balance between patient burden and all the questionnaires and all the research that you could do around such a trial. So thank you for the suggestion. It is something we are still looking at, but we have to be relatively restrictive. Yes.
Thank you very much, Robert. Any questions from the audience here? Yes, go ahead.
Hi, thank you so much for taking my question and for the very interesting presentation. I'm Giedra Piseckita. I'm a journalist from Politico, and I was wondering, because psychedelic therapy is not like taking a painkiller, right? Like it goes with the therapy. That's why therapy word is in there. So I wonder, could you comment how our regulatory framework is prepared for that? And what do you know about EMA preparedness to, look at your study's results? Thank you.
Thank you. That's an excellent and also not very easy question, because as you say, this doesn't fit the frames that we have. It's either a pill or it's a psychotherapy, and this is a pill within the context of a psychotherapy. I think Tadeusz is also going to address this a little bit. The EMA is now quite interested in it. Some of us will be in a session organized by the EMA next week in Amsterdam, which is specifically focusing on how to deal with these new upcoming treatments. And as you are probably aware, also the FDA in the US is sort of trying to find a way to organize this. And as different organizations, different companies, different researchers also have different approaches to this. So there's those who more lean towards this is a pill with support on one extreme, and the other is this can only be applied within a proper, more lasting psychotherapy frame. But we recently reviewed the literature on this, and what you see in the literature is that there's also there's quite some studies, but the you could say the proof of what is the best evidence-based approach is something that is still being worked on. It is very likely that the psychotherapy part is crucially important for these therapies, but we should acknowledge that there are also some publications showing that even with less support, changes can be achieved for patients. So I think the debate is still out there, and will definitely go on for the coming years.
Thank you very much. I'll take another online question. I'll make it a combined one from Alex from Psychedelic Care, which I think is a question that many others may also have, which is, as a patient, how do you apply? And then a second question from Ingmar de Gooijer, who's asking, as we know, set and setting are very important contributors to these treatments. How will you ensure a similar setting for all trial participants in different locations, which are not only different locations, but also different patient groups?
Yeah, so patients can apply through the medical specialists of the 4 sites that will include, starting in January 25. And we will communicate much earlier on the inclusion and exclusion criteria and ways to contact us and the other sites, and also through the patient alliances that are part of whom are present here. And then, so the patients will be screened both from in our center from the lung specialist COPD side and also from the mental health sites to determine whether they meet the inclusion criteria. We try to be broad, relatively broad, but also because this is a first trial of this scale, we want to be mindful of potential risks, even though we think they're relatively limited. And then the question about setting and context. So all the part of this project is that a therapy manual and a therapy training will be developed and will be fully written out by our collaborators in Copenhagen, Dea Sigard and her group, and all the therapists that will participate will be trained in the same standardized way. So we want to ensure as much as possible that the treatments are provided in a similar way across the center. And we will also look at whether this is done according to the agreed protocol. And this also involves influencing the room where treatment is given, the rest, the possibility to listen to music, to lower the light, etc., etc. And patients will also always be with a therapist, and there will also be a second sitter nearby, so that people will never be on their own.
Thank you. Yeah, time for a very brief final question.
Thank you. Thank you very much. Sorry. Very brief. So, Antoine Mial from FTI Consulting. You said in your introduction that this is the first project funded by the EU when it comes to R&D. You showed a slide that shows that there's a lot going on in that space. So, could you tell us a little bit from your experience? Is the EU lagging behind when it comes to R&D in that space versus, I'm thinking especially the US? Do you see much more trials funded by the NIH, for example? So could you give us a bit of a perspective there in terms of where we are in that space compared to, I would say, mainly the US? Thank you.
I think, I don't know exactly how many trials in the US are with public funding, my impression is that a lot of what's going on is with private funding in the US, and the circumstances for privately funded initiatives are really different. We are very happy that the EU is making this project possible. We do think that in this field, also given the complexities I just discussed, governments and also EU will be very important to step in to accelerate this process. I need to be brief because of the...
Yes, yeah. Just to add to that, to my knowledge, there's very little public funding also in the US. There are 1 or 2 trials funded by NIMH and NIH. But I think that the importance of public funding is that it can address some of the issues that typical venture-backed or investor-backed funding do not address, such as the possibility to offer peer support in the longer term and to pay more attention to a careful setting. Sorry, Olivier, I'll give you the opportunity to ask a brief
very
question
briefly,
also.
because it's a detail, but it's important to me. Olivier Tijmans from Psychedelic Society, Belgium. You produced a figure about depression and anxiety in palliative care settings of up to 80%. But this is something I looked up in the literature for personal work, and I found just half of it, like 40%. So where does your figure come from?
I don't have all the references, but there is a difference in the different conditions. We looked at the literature in the different conditions that we are going to include, and that's where we got it from. I can send them to you.
So it's disease specific?
It's disease specific, okay. And they're not as high in all of the disease, all of the 4 categories. Okay. So they range somewhere from 30, 40 to even around 80.
Okay, thank you.
Yeah.
Thank you very much, Professor Schulvers. Thank you very much for the online audience. There were many additional questions that could not be addressed. We're moving on, and we'll hear next from Dr. Lauren McDonald, who's a psychedelic trial doctor and therapy guide, but who's also a patient with cancer who has personally received the benefits of psilocybin. And she's not with us here in person, but she's provided an online testimonial.
Hello everyone, it's lovely to be with you, and I am really thrilled that the PsyPal clinical trial is going ahead. It's such wonderful news, and I really believe it will impact the quality of life of so many patients in such a positive way. And yeah, I really say that as somebody who has lived experience of existential anxiety as a result of a stage 4 cancer diagnosis. And I subsequently experienced psilocybin, and it was incredibly healing for me. And I only wish I'd had access to it much earlier on in my cancer journey. So I thought I would just share a little bit about that journey, what it's looked like, and why I'm so passionate about psilocybin therapy. So I'm now 39 years old, and I was diagnosed with melanoma when I was 29, so 10 years ago. And at the time, I was a junior doctor. I just started working in the NHS. And I ended up having a misdiagnosis for the initial cancer. So by the time I was diagnosed, I was stage 2, but very quickly moved to stage 3 with cancer in my lymph nodes. And then a year later, it was stage 4 with cancer in my lung, adrenal gland, and the chest wall in my right upper breast as well. So I had numerous surgeries over a few years, and because it was metastatic melanoma, unfortunately, that particular cancer doesn't respond well to chemotherapy or radiotherapy. So by the time I had stage 4 disease, and every time the tumours were surgically removed, cancer would come back, I was told that for now, there was no further treatment for me. So I was 31 years old at this point. And I was told that there was a chance there might be some clinical trials that I would be eligible for, but at the moment that wasn't the case. And that my team were hopeful that there was a new drug called immunotherapy, which might become available on the NHS. But it was all very unknown for a few months. So I really had a huge journey in those years, going from a very fit, healthy 29-year-old to, by the age of 31, having stage 4 cancer and not knowing if there was going to be any further treatment for me. I was told to do my will and to really kind of prepare for end of life. Although I still felt relatively well at that point, there was this sense that the disease would continue to progress unless I managed to get access to some treatment, which fortunately did happen. I was able to get access to immunotherapy about 3 months after being told there was no further treatment, which really was a miracle. And 4 months later, I was told I had no evidence of disease. And gratefully, 7 years later, that is still the case. I actually had a CT scan and an MRI scan this week as part of my routine surveillance at 7 years. And I am in that place where I'm actually waiting for results at the moment, but feeling positive, and really hoping that these will actually be my last ever scans, and then I'll be discharged finally. So yeah, being asked to make this video at this moment feels very poignant. Just a chance really for me to reflect on the huge journey that I've been on over the last decade, and how fortunate I am to be here, but also how passionate I am about helping other patients facing end of life or facing cancer-related distress, any illness really that potentially shortens life, to help those patients get access to psilocybin therapy. Because it wasn't long after I was told I had reached no evidence of disease that I found out about psilocybin therapy. I came across the research at Johns Hopkins University and was fascinated by this new therapy that I hadn't heard of, that had really helped a lot of patients with cancer to process and face existential anxiety. And even though I was in remission by this point, I definitely still had a huge fear of the cancer recurring. I'd had years by this point of having CT scans and being told that the cancer was back or that it progressed. So there was definitely an ongoing fear that it was going to come back. And I had a huge fear of death. I think being diagnosed with cancer at 29, really facing my mortality, had been huge for me. And there was a lot of existential questions that had come up around, had my life had meaning? What had it all been about? What was it going to be like to die? Was I going to suffer? I'd also felt incredibly alone during that time, despite having amazing friends and family supporting me. There was this sense that nobody else could quite understand what I was going through and just how huge it was. I remember for years, and this was even before I progressed to stage 4, so probably relatively early on in my journey, I started waking up around 4 in the morning and would suddenly be struck by how alone I felt. And there was a sense that we come into the world alone and we die alone. And it just felt incredibly lonely and scary and finite as well. That death was coming for me, that I was going to die soon, and that was it, that was the end. So there was also a lot of sadness around the life I wasn't going to get to live, the experiences I wasn't going to get to have, having a family, buying a home, all of these things. As a newly qualified junior doctor, I felt like I'd just been getting started. And then suddenly all of this was being taken away from me. And there was also guilt as well. I felt really awful for my parents having to go through this, seeing one of their children suffering, and just how much this was taking a toll on them as well. So there was a huge amount of both psychological and existential suffering during those years. And it wasn't until I found out about the research with psilocybin that I decided to go off to a legal psilocybin retreat in the Netherlands. This was in 2018. And I went with the intention of processing what happened to me, addressing my fear of death, addressing my fear of cancer recurrence, and just being open to whatever healing needed to happen. I'd never taken psychedelics before. I was completely naive, and I was really blown away by the experience that I had. There was so much in my journey, in my psychedelic journey, that has really helped me to this day. And some of it was very cathartic. There was a lot of crying in my journey, a lot of compassion, forgiveness, a real sense that I was so proud of myself for what I'd been through and how strong and resilient I'd been. But the biggest kind of takeaway and the insight that has really helped soothe me and keep me centered and really truly has got rid of my fear of dying was the experience that I had in the psychedelic state during the journey, where I had full ego dissolution and got to experience myself as energy. And in that state, I was able to connect with many of the cancer patients that I had met over the years on the chemo unit, the immunotherapy unit, and got to communicate with them and got to hear from them. They were able to tell me that, yes, their physical body is no longer here. Yes, they've died, but they still exist. They're still an energetic essence, and that I only need to close my eyes and kind of tune into that whenever I want to connect with them. And they also just let me know that if the cancer comes back, if I die, of course, that will be very sad. And at the same time, that I need to just know that I will continue. I will also return to my energetic form, my true essence, and that I could just carry that with me, that it wasn't going to be finite and that I wasn't going to be alone, and that I was supported and loved. And there was just a real sense of love throughout my psychedelic journey as well. A sense that I was so grateful for all the love and care that I'd received from friends and family and oncologists and just everybody really who'd been involved. But also that I was able to beam that love out to all of them, and just really with the most immense gratitude for everybody. So that was incredible to just really be in that amazing sense of love. So it was a really profound experience that I had. I came away from that retreat with such a shift in how I felt about death. I still didn't want the cancer to come back. I didn't want to die. Of course, I didn't want to leave my friends and family, but there was this sense that it would still be okay. If the worst thing happens, if I die soon, that it will still be okay, that my essence will continue, and that I will be able to beam love at everybody from that place. And I wasn't really going anywhere in that sense, even if my physical body was going to die. So obviously that was my experience, but it has been so helpful. As I said, I'm now waiting for my scan results. And in the past, that would have sent me into such a spin. There's something called, scan anxiety, and it's very visceral, it's very somatic. That week or two when you're waiting for results is always so difficult. And of course, with the benefit of time and the benefit of having these scans with no evidence of disease, that has definitely contributed to my sense of calm and peace. But I would say more than anything, it was the psilocybin experience. It really was a huge shift just from that one experience. I was left with less anxiety. I was left sleeping well. I just felt much more composed and peaceful. And there was also, and this has continued, just this sense of awe and curiosity about the great mystery and death, and the sense of not knowing what happens when we die and being okay with that. Just, this is the mystery and we don't need to know. And I think for somebody who wanted certainty and really struggled with the unknown, especially at the beginning of my diagnosis, to be able to sit in that are known now without that sense of anxiety. And yeah, existential distress is amazing. So I'm hugely passionate about this area. I really do feel it will change lives, and I'm excited to follow along and see the results. It's wonderful as well that it's not just focusing on cancer patients, that it's being broadened out. And I'm actually working, well, I have been working as a clinical trial doctor and psychedelic therapy guide at the Centre for Psychedelic Research at Imperial College London for the last 2 years. So I've also been able to work on some of the psilocybin trials and supporting other groups of patients to go through this treatment. And it's just incredible. So super excited. Yeah, huge thank you to everyone who's been involved with this. It's amazing, and just wishing you well with your trial.
She's not here with us in person, and she really wanted to be here for Q&A, but unfortunately, Lauren is in an area that didn't permit her to join via Wi-Fi or 4G otherwise. But thank you, I think, on behalf of all of us, for a very beautiful and moving testimonial, and the importance of this this treatment, and showcasing that it's not just a new kind of treatment, but a really new paradigm. Yes. In the interest of time, I'd like to move on to Martin Luschka, who's also not with us. Martin is a distinguished member of the European Alliance for Palliative Care.
Ladies and gentlemen, it is a great honor for me to be
And he's already here.
Oh.
Okay, you can finish. Yes, okay. He has established the Center for Palliative Care in Prague, in Czechia, and is a psychologist, researcher, and educator in this field. So I'll give him the floor.
For you today, as we embark on this groundbreaking journey to explore new ways of assisting patients nearing the end of their lives. My name is Martin Luschka. I'm an assistant professor of medical psychology at the Third Faculty of Medicine at Charles University in Prague, a board member of the European Association for Palliative Care, and I also work clinically as a psychologist in the Department of Palliative Care at Tomayer University Hospital in Prague. I would like to share a few thoughts regarding the potential use of psychedelics in palliative care, and express the hopes that I personally, as well as many of my colleagues across the European community, hold for the PsyPal project. It is particularly special for me to speak at this wonderful event, as I have been a scrutinous critic of psychedelics since this topic gained momentum several years ago. Some may perceive this entire topic as an eccentric movement led by a group of former hippies, detached from modern mainstream medicine. Yet here I stand, a teetotaler who has never even tried a cigarette, genuinely enthusiastic about this project. Allow me to explain why. As a psychologist in palliative care, and I believe this sentiment is shared by others in our field, we frequently encounter patients struggling with anxiety, depression, and the pursuit of meaningful moments in the time they have left. While I take immense pride in the current capabilities of palliative care as a crucial support system for many patients and their families, there remains a subset of individuals who require something more or something different to cope with their profound and burdensome circumstances. Traditional psychotherapy in this population often presents challenges due to the patient's clinical conditions, constrained time for interactions with the team, and the differing evidence base supporting psychotherapeutic interventions compared to those approaching the end of life. Despite the emergence of innovative psychotherapeutic approaches tailored for our setting, such as dignity therapy or the calm therapy developed by Dr. Gary Rodden, these methods, though commendable, may not meet the diverse needs and preferences of all patients. I would like to underscore 3 key aspects of the PsyPal project that I believe underscore its significance. Firstly, the project is meticulously crafted, rooted in a robust methodology and engages an outstanding international consortium comprising esteemed researchers and clinicians possessing extensive experience in research with this vulnerable population. Frankly, if this initiative solely emanated from a group of unwavering psychedelic advocates, I would be the first to voice my reservations. Given the contentious and hazardous nature of this field, rigorous research is essential to ensure not only the proper execution, but also the safety of such interventions. Secondly, I wish to highlight the project's focus on patients with diseases other than cancer. Most evidence supporting existing therapies, as previously mentioned, primarily stems from cancer research. The decision to explore interventions for patients with different conditions reflects a bold and laudable move, and I want to also commend the European Union for prioritizing this area in their Horizon Europe program. Diversifying our experience and evidence base for those grappling with diseases beyond cancer is both compelling and essential. Lastly, the commendable international scope of this project merits appreciation. Given the challenges associated with controversial issues like psychedelic use, the implementation and dissemination of research findings can be difficult due to legal and cultural barriers that may impede broader adoption, regardless of potential efficacy. From this standpoint, undertaking the PsyPal project on a European scale represents a strategic and courageous endeavor that may expedite discussions on the necessary measures to make such treatments accessible across Europe upon positive study outcomes. I would like to extend my gratitude to Professor Schubers and all of the colleagues within the consortium involved in this project. Speaking partly on behalf of the EAPC and partly as a fellow researcher and clinician, I am genuinely thrilled about this project and wish you all the best in this forthcoming adventure. Thank you.
Thank you. We'll move straight on to Dr. Els Verschuur, who will be presenting on behalf of Dr. Orla Galvin as well, the Executive Director of the European Federation of Neurological Associations, EFNA. And Dr. Els Verschuur is associated with the Lung Alliance in the Netherlands. The floor is yours, Els.
Thank you very much. Can I have the next slide? The next slide is picturing all the members of EFNA. I will not mention them then all, but EFNA is an umbrella organization with many members. Can I have the next slide, please? Relieving serious health-related suffering for patients in palliative and end-of-life care, be it physical, psychological, social, or spiritual, is a global ethical responsibility. However, the profound psycho-emotional and existential distress entailed by such suffering, despite often being an enormous burden for both patients and their loved ones, remains a field largely overlooked by healthcare providers and the scientific community. Those people may develop mood or anxiety disorders for which neither non-pharmaceutical, pharmacological, nor pharmacological intervention exists. Next slide, please. Patient involvement serves a different purpose in every phase of the research and will have different designs at each of these stages. In the right corner, people can be involved in development of the research question, the study design, in seeking funding, in carrying out a research, analyze results, write scientific publications, and share research. Next slide, please. There are different approaches to patients and public involvement. You can be informed, you can consult patients, patients can advise, can co-produce, co-decide, or the approach can be patient-driven. Next slide, please. So what is the impact of patient and public involvement in research? Next slide. Here's a quote of Maarten de Wit. Direct involvement of stakeholders contributes to an enrichment of research agendas and ensures that research results better meet the needs and the wishes of end users. Patient involvement increases the legitimacy of scientific research. Next, please. Patients and public involvement can lead to more relevant research questions, can improve research designs and approach to research tools and methods, can more refined and relevant funding applications, leads to more successful recruitment and retention of participants, more in-depth interpretation of research results, and wider dissemination of study findings. And the impact of patients and public involvement are the following. Studies are more likely to meet the needs of patients. Studies could potentially have an increased chance of being funded. The research is more ethically acceptable. Researchers are motivated and knowledgeable about the condition. Project results can be disseminated more widely and be applied earlier. And patients are more empowered, and that's the primary goal of the WHO. And that's the part of Ola. So I will continue with my part, okay? So I will zoom in a little bit more in detail on patients with severe COPD. There are several reasons to involve people concerned in developing policy, conducting research, and designing care and support. And the main reason for this, in my opinion, if you don't, outcomes and interventions are more likely to miss the mark. Can I have this slide? In the Netherlands, this is a slogan we use more and more. Nothing about us without us. Next slide, please. However, involvement of patients with severe COPD in research requires knowledge of the characteristics of these patients. COPD is a life-threatening disease with an unpredictable disease trajectory. It is one of the top 3 causes of death worldwide and number 5 cause of death in the Netherlands. People with COPD have a poor quality of life with high symptom burden, similar or even higher than patients with incurable lung cancer. And they have an increasing dependency, and it is not only grieving for patients, but also for informal caregivers as well. And the family caregivers have a high caregiver's burden. Next slide, please. As said before, patients with severe COPD have high symptom burden. They often have more than one symptoms at a time. And as you can see on this slide, in the last year of life, all these symptoms occur in more than 50% of patients. In addition to this, a lot of patients suffer from feelings of guilt because of the smoking they did, social isolation, mostly because of physical limitations, and fear for suffocation. So I think you can imagine that patients generally experience poor health and that they are limited in a variety of daily activities. Next slide, please. In addition to the high symptom burden, more than 50% of patients have low educational level and a low health literacy, limiting their understanding of their disease and prognosis. Does that mean that these patients cannot participate or being involved in research and development? No, quite the opposite. Next slide, please. Knowing the characteristics of patients with severe COPD and consulting with them or a representative of them about their options and possibilities can be very helpful in designing and conducting research. For instance, when it comes to the feasibility of the study or elements of the study, or when it comes to measurement tools, interview, think for instance of short sentences, straightforward language use the same language patients use and use the same words patients use, and don't use metaphors, they take that literally. Concerning to the questionnaires, not too many items, not too long, and make use of a research nurse to help filling in the questionnaires. and in interviews take sufficient time and have frequent breaks if needed. And with concern to the dissemination of study outcomes, patients tend to be much more committed when they have been involved. Next slide, please. So I'm very happy to be involved in the EU PsyPal projects as a representative of patients with severe COPD, and namely in Work Package 4. There are three tasks in Work Package 4 I'm involved in. Public and patient involvement coordination, the patient monitoring and support for continued care, and the peer support networks. And as I started my talk, nothing about us without us. Next slide. So thank you very much for your time and for the opportunity to speak on behalf of patients with severe COPD. Thank you.
Thank you very much, Els. We'll have some time at the end for questions and answers, so if you don't mind, we'll save that for then. I'd like to also welcome and acknowledge the presence of MEP Sara Cerdas from the SED from Portugal. Welcome. And then we'll move on to the next speaker. My right hand, your left hand neighbor, Tadeusz Havrot, the founder and executive director of PAREA, the Psychedelic Access and Research European Alliance. Floor is yours, Ted.
Thank you, Joost. I'll try to save a few minutes on my presentation, so pardon me if some things are going a bit fast, but all this will be available in the recording. And also I take the opportunity to give a warm welcome to Tilly Metz from Greens, another MEP. We are really lucky to have so many MEPs present, which is also, I think, saying something about the importance of this work. But coming to my slides, this is PAREA. It's a membership-based organization, which first of all brings patient groups, because this is why we are doing this work. This is for people who need more treatment options. We have patients in the area of mental health, of course, but also neurology and chronic pain. Scientific societies such as European Psychiatric Association and others, and also psychedelic foundations. And some of these members are also members of the PsyPal. Next. Our mission is integrating psychedelic therapies into regular healthcare settings. We want to see a safe, modern, and ethically responsible integration of those therapies. We want people to have them accessible at the place where they live, from the doctor that they trust, and paid by health insurance. And you see here a quote from Bill Richards, which I think is also echoing with what we heard earlier from Martin. This is no longer some eccentric field. We are really talking about addressing some deep-seated people's needs, mental health needs. Next, please. It's always useful to have a context. Robert was speaking about the prevalence, but you know, the situation in mental health hasn't been really improving, to put it mildly. It's growing. You might have seen the 1 in 6 number, but the OECD is showing us that 1 in 2 people during the lifetime will be affected. And there are even studies. This is a Danish study published just a few months ago based on an observation of 1.5 million Danes that shows that the lifetime prevalence can be even as high as 4 out of 5 who either receive the diagnosis or prescribed psychotropic medications. We know we have obviously treatments, and antidepressants are helping a lot of people, but there are also a lot of people that they are not helping. These are mostly numbers from WHO, which show that 3 out of 4 people with major depression, for instance, do not receive adequate treatment, or half of people who are treated experience incomplete treatment response or full resistance. You know, we think about mental health conditions as chronic conditions, but they are also deadly. 1 in 3 people with treatment-resistant depression will attempt suicide at some point in their lifetime. And we know from WHO, in the WHO Europe region, 130,000 people die by suicide every year. So it's not just that these conditions decrease our quality of life. And also we know that Depression increases the risk of anxiety disorders, of addictions, and other non-communicable diseases such as diabetes and heart disease. And the opposite is also true. People with these other conditions have a higher risk of depression. And here, of course, PsyPal is doing exactly that, looking at different conditions in palliative care that have this comorbidity with depression. And we haven't been really doing great in terms of innovation, both in the larger perspective for decades. There haven't been really any true breakthrough treatments and innovations, just tweaking the existing molecules. And in Europe, you here can see data from 2022, but they are the same for last year. There was no treatment, no new treatment approved in the last 2 years for psychiatric conditions. In the last 3 years, so in 3 years, there was one, compared to 68 in oncology. So we can surely do better. And here, now we can start talking about psychedelic therapies. We know that they can work for people for whom other treatments didn't work, for treatment-resistant people, for a proportion of them. They have different mechanisms of action, and it's important for overall health outcomes, also because we can possibly combine different treatments, just like we do, for instance, in hypertension. They have they work fast, which is another important thing, especially with people with the increased risk of suicidality. And as we were already discussing earlier today, there is this experiential and psychological and therapeutical component. We are no longer just administering pills. We are, in a way, putting people in the center, and rather than masking symptoms, we are really creating this model of healing where psychedelics help people address their core psychological problems. There was a number of regulatory advances in the last few years. You can see here the FDA, the equivalent of the European Medicines Agency in the US, gave breakthrough therapy designations for different trials for treatment-resistant depression, MDMA for post-traumatic stress disorder, which is also particularly important in the context of wars now. We also have major depressive disorder, and this year, 2 new breakthrough therapy designations for 2 companies that are actually para-industry partners, MindMed for LSD treating anxiety, and psilocybin as an adjunctive psychedelic therapy for major depressive disorder, companies called PsyBin. And also, last year, Australia became the first country to officially regulate the medical use of psychedelics and provide a kind of restricted access. And perhaps most importantly this year, it's quite likely that the first psychedelic therapy will be approved in the US as early as in a few months. We'll see. This is based on this 2 pivotal phase 3 trials looking at MDMA-assisted therapy in PTSD. And that's also, it's worth mentioning that PTSD is not only people who are veterans or exposed to war zones. Actually, the majority of people with PTSD are women. And, we are talking here about domestic violence, sexual abuse, and so on. I think in Europe, the prevalence is 7 or 8 million, and this is a bit of a blind spot. We are really not speaking about the PTSD. We speak about depression, maybe addictions, but PTSD is really something that is quite of a health threat. And the treatment sizes here you can see are quite impressive. And even though this does not necessarily have to translate to the same efficacy in the real world, even if we can help 5 or 10% of patients who are not helped with other treatments now, I think this is a reason to celebrate. So we are very much hopeful that these trials and this work will confirm that, and we will see this real world efficacy. In terms of safety profile, one thing is that obviously these drugs are Schedule I drugs, and the schedule actually mentions that they have no currently accepted medical use and a high potential for abuse. And you can see here comparative studies looking at different drugs and the kind of relative harm. And alcohol is at the beginning, and then you have substances like crack cocaine and heroin. And funnily enough, psychedelics are rubbing shoulders in a way in this classification with these substances. We know the classical psychedelics have a low potential for addiction. They are also not necessarily harmful in the physical way, but surely they are powerful tools psychologically, and they should be kind of approached with a great care. And there is a lot that we should be doing as a community to make sure that people are supported, especially when they go through difficult psychedelic experiences. There has been an explosion in the research. This is the graph that covers more or less 20 last years. So it's showing an increase in clinical trials and increase in publications. I want to mention that there are no shortcuts here for psychedelics. They have to go through, time-consuming, costly, arduous clinical trials, just like any other evidence-based healthcare intervention that is then approved by regulators. So they are following the same development path. And we also have a number of scientific centers that have been opening in many prestigious locations. Actually, the first one started around 5 years ago in Imperial College London. And there are others now in UCL and Johns Hopkins and other prestigious places all over the world. Next again, and these are some of the investigated indications. We are obviously speaking a lot about psychiatry, depression, anxiety, substance use disorders, but there are also trials looking at a number of neurological conditions, chronic pain, migraine, even traumatic brain injury, and so on. This is not to say that we'll be seeing all these treatments available to patients tomorrow, but the science is exploring their potential usefulness in these areas. So surely something we should be supporting also with EU funding. This is some of the progress in the EU. Last year, the EMA released this commentary in the Lancet. This was the first time when we heard from European regulators, both voicing cautious optimism and encouraging, more attention. The EMA said last year that there has been 16 ongoing clinical trials with psychedelics in the EU. And as Robert mentioned earlier, just next week, we'll have a 2-day multi-stakeholder workshop on psychedelics organized in Amsterdam by the European Medicines Agency. So I think this is a very clear sign in Europe for everyone that this is something that our main drugs regulator is looking at very seriously. And 2 last slides, I want to mention some EU policy recommendations that PAREA has. As we heard already, we have issues with mental health conditions, with innovation, but at the same time, we see that psychedelic drug developers, and these are mainly smaller biotech companies, are focusing on the US for a number of reasons. And maybe, there is no enough attractive regulatory framework here, so we should be creating one, both in general for innovation, but also for innovation in mental health, because it looks for now like there will be first approvals happening, or Australia already approved psychedelics, US this year, and really there is no approvals in sight in the next few years, 3 to 5 years, I can't think of anything. So we should be better at attracting large scale pivotal trials that could lead to approval, and hopefully PsyPal project could produce the data that could, be enough powered to consider the approvals. I'm mentioning here some ways to encourage innovation, such as incentives. Now we are discussing the pharma legislation. There are regulatory protection, kind of levers, enhanced support from EMA, and other ways that could attract both bigger companies and also support smaller companies and, of course, academic developers. On top of this, PAREA is calling for a creation of a European hub for mental health R&D to better coordinate this at the EU level. And that's not just, psychedelics. Of course, amplifying EU-funded research. And again, we are very pleased with PsyPal. Have a kind of bigger attention towards the real-world evidence, and of course, increase the role of patients throughout the whole kind of regulatory process. And finally, our key recommendation at this point So we acknowledge that one of the main challenges will be to translate the findings from clinical trials to healthcare settings, because psychedelics take much more than just, producing pills. They will take expertise and infrastructure. So we need this mechanism that would allow for a collaboration between member states and other stakeholders to move towards safe and equitable access. So what we are calling for is this pan-European multidisciplinary advisory board, or a EU Commission on novel mental health therapies that could work towards developing a comprehensive framework for sustainable psychedelic care models, and it would address areas such as standards of care, training and licensing requirements, ethical and safety standards. And it would really show this added value that the EU has, because rather than have countries working one by one on the same issues, there surely is an added value of a EU collaboration. And this could take a shape of, I have a few ideas here, a EU for Health project, such as EU-led joint action, bringing together different member states, a EMA pilot, a subgroup as part of the EU expert group on public health run by the European Commission and bringing together all the 27 member states, a European partnership on innovative mental health treatments as part of the upcoming framework program on research and innovation. We now have Horizon Europe, which with new partnerships, there is a partnership on brain health in the next cycle. It would be good to have something looking at mental health, and a EU high-level conference would be also very fitting to address all these issues. Thank you.
Thank you very much for a very comprehensive overview, Tadeusz. To wrap up, I'd like to give the floor to our distinguished MEPs, and recognizing also Tomislav Sokol from the European People's Party. Very warm welcome to you as well. Please, if you would like, I'd like to invite you to offer your reflections, suggestions, questions that you may have.
Okay, thank you very much. I will start. I think that we can see from Laura's experience and experiences that this testimony was very strong for us and important, and also believable for many people. As was described by guests, experts and patients, psilocybin therapy has shown promising result in elevating psychological distress in palliative care patients. This approach is not merely about managing psychical symptoms, but also about addressing psychological and also emotional well-being. Clinical studies have suggested that psilocybin can significantly reduce anxiety, depression, and existential distress often experienced by patients with life-limiting illnesses. This therapy, administered in controlled settings and alongside psychotherapy, can offer a sense of peace, closure, and acceptance to these patients. It was really amazing to hear more about this, and we need to discuss how to help to realize the potential of psilocybin therapy in palliative care at the EU level. I believe that firstly, there is a need for data. We don't have enough data, as you said. We must gather comprehensive data in the EU level to understand how psilocybin can be best used in a diverse patient population. Clinical trials are essential and must adhere to high standards of scientific rigor to ensure that safety and efficacy of the therapy. Additionally, we need to establish a supportive regulatory environment. This is, of course, a very long run, I know. It involves creating guidelines for the safe production, distribution, and administration of psilocybin, and ensuring that it is only used in a medically appropriate context. Regulations should also include standards for training healthcare professionals who administer this therapy. To effectively implement psilocybin therapy in palliative care, education and training of healthcare providers is also crucial. We need therefore develop specialized training programs that equip professionals with the knowledge and skills necessary to administer the therapy safe and compassionately. Moreover, in my opinion, the EU can play a really critical role in public education and destigmatization efforts by promoting awareness about the therapeutic potential of psilocybin and the scientific research behind it. We can address dismantle any misconception or stigma associated with its issue. In my conclusion, the journey towards integrating psilocybin therapy into palliative care is not without its challenges. However, these challenges present us with an opportunity to significantly improve the quality of life for our most vulnerable citizens. I am very happy to be here today and hope that this effort to evolve our healthcare system to embrace innovative and beneficial treatments like psilocybin therapy will continue during the next mandate as well. Now I think it's the right time for advocate for this type of therapy. Thank you very much.
Thank you very much. Yes.
Perhaps I'll take the floor next and we'll follow the order that we have here in the agenda. First and foremost, thank you very much for the opportunity to be here and reflect a bit of what has been some of the discussions that you guys have had here today. And as Tadeusz mentioned, and also the previous presentations, the epidemiological numbers of mental health conditions are quite incredible, not in a positive way, not only in the EU, but in the world. And I think this is a set of conditions and pathologies that hasn't had many curative advancements in the last decades, not only in the last years. And this is it's kind of, it's not the same obviously, but it's kind of like what we have with antibiotics. But it's important to reflect that we are here not talking about acute disorders or infections that can go after 1 week. We're talking about here mental health, which has been a part that has been very much in the closet of not only the EU, but national governments and daily life. Now it's much less stigmatized to talk about your mental health conditions and how you have different types of support. I came running from the cafeteria, from the canteen, having lunch, and just by my side, I was overhearing the conversation, and he was talking. Oh, I talk with my therapist about my new job prospects, and just the fact that openly someone is talking that they go to the therapist, and I think everybody is quite impressed, because this was not a reality just a few years ago. So I would like to highlight that, and that's something that we managed to include into our mental health report, which is the first position of mental health here in the Parliament. I won't take much time, because I was told we only have 5 minutes to reflect, but I'm quite impressed by the numbers that and the steps that Australia has given. And I already had the opportunity to convey to the director of EMA that we cannot stand behind, and we need to take the proper steps. Here in the EU, we represent almost 500 million people, and we cannot let them without these types of tools. I'm also I would also like to reflect what is our roles here as parliamentarians. And just in a few slides, we see that many projects come from the Youth for Health program. The Youth for Health program had an increase in budget from 10% to 25% for prevention and prevention. And this is quite important because here, when we're talking about psilocybin-assisted therapy in palliative care, we're talking about tertiary prevention. So we're also talking about prevention in the public health sense of the word. So to reflect on that, you also call for a mission in mental health. That's something that we want in our report here of the Parliament. We want more funding and specific research. There's so much opportunities here in this block. And talking about opportunities, and you have here in the table three, and Tomislav, the main negotiator of the European Health Data Space that we just voted this morning, and the opportunities and the doors that will open. So they're congratulating each other, and congrats to Tomislav. We made it. Next step is the plenary. Just to reflect, the work that we do here in the Parliament matters, but it could not have done without you and the support that you give to the MEPs. I usually say, and I say it because I didn't invent it, it's what it is, 70 to 80% of laws, legislation of Portugal comes from the EU. And we are very few for what we do here, even though we have incredible teams with us, but that could not materialize if we didn't have the support that we have from different stakeholders involved in the EU teams. So keep going the great work. There will be more challenges in the next mandate, but please don't let us lose the momentum to build a true European Health Union, and that includes mental health, and that includes palliative care, and that includes novel therapies that can open incredible doors and help soothe suffer for those that are in this very specific life stage. It can be the end of life, but they can get out of it. But at least aids in the suffering and the psycho-spirituality around it. So I think that those were my reflections, and please keep supporting the MEPs. I would like you to thank you if I don't know if I will have more opportunities to do so. So thank you for your collaboration in the past 5 years for us to finally have a mental health report and and we're talking about psilocybin-assisted therapy in palliative care. I don't think we could ever imagine of that, Tadeusz, when we first spoke in 2019, 2020. So thank you very much, and keep going for the next mandate.
Yeah, thank you. Before we go to the next speaker, I just want to mention that we are already over time, but we'll take another 10 minutes and give you enough time to deliver your intervention. But thank you very much, MEP Cerdas.
Okay. But I was the last one to arrive, so, but okay. Thank you very much. Thank you for inviting me. It's hard to say anything original after the previous speakers, and I apologize for not being able to come at the beginning. And I have to say I'm really not an expert on this very particular specific topic on the use and more general on the use of psychedelics in tackling brain disorders, but I can say some things in general which I think are important, especially at the end of this mandate. So first healthcare was before this mandate of both the Parliament and the Commission a marginal topic in Brussels. So this was something that was really not considered very, very important, but this has changed. Of course, obviously, to a large extent because of the COVID-19, but also this also gave us opportunity to push for other health topics as well, like Europe's Beating Cancer Plan, the mental health report, which was, I think, really, it is a good example of something that was done because of the political pressure from the Parliament, which really made Commission actually do something on this. So I think now we have the momentum, and healthcare has really become something very important here. And the crucial thing is, and that's my most important message, is to keep this momentum going, because we already seen that since the end of the formal end of the pandemic that healthcare is again not in the focus as much as it was before. Now we have other issues like energy crisis, inflation, war in Ukraine, and other topics as well, war in Israel, etc. So I think that that what is crucial is really to keep this momentum, to keep this pressure, not just in the Parliament but also to other policymakers, especially the Commission, because the Commission is the one who has the right of legislative initiative, so everything comes from them. We can put pressure, we can make amendments, etc., but they are the ones who have to come up with new policies. So I think this is very important. This kind of advocacy is very important, and I hope that these kind of events will also continue to be happening also in the next parliamentary mandate. I would like to focus on two areas, or maybe one, but relating to two reports that I've been working on, and that was mentioned in the last presentation: the importance of data and the importance of research. So I think that this is something that we've really done a lot here in this mandate. So as Sarah said, we adopted in the relevant committees the final agreement on European health data space. We of course need to have the final vote in the plenary, the very last plenary, probably on the very last day or the day before of this mandate. But I think that despite the fact that we had to make some compromises with the member states, the end result is something that is positive and that will really bring a lot of benefits for patients. Of course, the main topic was about secondary use of data, so the use of data for research. What was important for the Parliament was to have common European rules on that, so that member states cannot have full autonomy to decide what kind of rules they will have on secondary data, whether there would be an opt-in or an opt-out or whatever. And I think that the end result, the compromise where we have a general opt-out with some very specific targeted exceptions, is the best possible compromise that we could have get. First, I think opt-out is a good solution because it makes it possible that on one hand we have data which is representative, which is for research crucial, that it's not biased or not as biased as with an opt-in, but on the other hand that we also give patients the right to choose whether their data should be used for research or not. So I think that this kind of compromise is good. We have some exceptions for the member states, but these exceptions, and this is what I will communicate, are not carte blanche. So member states cannot just say we will override opt-out whenever we want. So they can only override opt-out if they have a clear public interest justification, and if this is the least restrictive means to achieve the public interest result. So only if there is no other way can they override the opt-out. So I think that this kind of approach, which is also subject to judicial control, judicial scrutiny, is something that really brings this balance between the interests of patients and research on one side, but also patients' right to choose. So I think that HDS will really make a difference for patients suffering from brain disorders. I agree with Sarah. This is one of the least not least research, but maybe the area where we have the biggest untapped potential of research, and here we really have to do a lot. The other point I wanted to make was about the pharma package where we are only finishing the first reading at this plenary, really, but I think which really also strikes this balance between the need to have strong data protection on one side, but to really focus this regulatory data protection, market exclusivity meaning incentives for pharma industry to develop new treatments in those areas where we need them the most. So we have now the unmet medical needs, high-unmet medical needs. So we really are focusing now the incentives on those areas where where the needs are the biggest. And I think it's particularly brain disorders this is one area where we need new research, or we need innovation the most. And I think that this kind of focus of the pharma package is really a good way forward. And the very last point on the budget, unfortunately, you know that EU for Health budget has been reduced by 20%. This was definitely a setback for us. This is not something that is good for health. And we will definitely continue to fight, us or the ones who come after us in the next mandate. We will fight to get this funding back, but also that in the next multi-annual financial framework we have even stronger and bigger budget for health, because needs are big. We need especially on research and implementation of all of these strategies, public health programs, etc., etc. So definitely fighting for the budget will be of extreme importance if we want to really have a strong common European health policy. And I think in the area of brain disorders, this is one area where we can do probably the most. So Thank you again. Thank you very much for inviting me. I want to commend you for all the work that you are doing, and I hope that we'll continue to collaborate in the future.
Thank you very much. I will be very short, or I try to. First of all, I'm really happy that the European Union now decided to allocate funding towards a well-designed contemporary study meeting the criteria of evidence-based science. So that is good news that we have today, because this is really a significant initiative as we navigate discussions surrounding the therapeutic application of psychedelics. In recent years, we have witnessed that what many have termed psychedelic renaissance, where these substances have emerged as potential really game changers in medical treatment. So the UN World Drug Report of 2023 notably acknowledged this shift, recognizing that not only traditional, spiritual and recreational users of psychedelics, but also their newfound potential for addressing really certain psychiatric conditions such as, and you mentioned them already, depression, drug and alcohol addiction. As our understanding of psychedelic deepens, it becomes increasingly evident that they could revolutionize really mental health care, and also, and you mentioned them, I'm happy, other diseases like neurological diseases. And I'm really saying that I was chairing in Luxembourg the Multiple Sclerosis Association for 11 years, so also for multiple sclerosis, but also for other neurological diseases, this can play an important role. However, as with any medical intervention, it's crucial to approach the use of psychedelics with caution, of course, and a solid foundation of scientific evidence. As we move forward, there will come a time when we are tasked with designing a regulatory framework that strike balance between accessibility and safety. This is where the importance of well-designed studies like the one supported by the EU funding through Horizon Europe cannot be overstated. So now on me also, I try to be short. I wish you all the best for the study, and I really look forward to the results that are coming out there. And I hope I can continue the fight for psychedelics in care and palliative care, especially also in the next mandate. And I'm very happy to be part of this action group for medical use of psychedelics. So thank you very much for having me. Thank you.
Thank you very much, all four of you. And as you may have guessed, this leaves us with very little time for questions and answers, to be precise, none. So Fred, Vice Chair of PAREA and Executive Director of the European Brain Council, the final minutes are yours.
Well, thank you, Joost. Actually, I had prepared a longer conclusion, but given the 2 minutes remaining, I'll be extremely short. Particularly as the contributions from MEPs to this meeting came really to the final words that I wanted to convey, is the demonstration of these collaborative efforts that Tad was calling for. We came here as a community of scientists, of researchers or clinicians, but also having the testimonies of people with lived experience, and coming up with a certain number of needs in order to make emerge what is a great potential in the brain space. So obviously palliative care was one of the examples, but Robert, you provided quite a few tracks where this can definitely lead us in a way to address the stagnation innovation in the space. So obviously funding has been resolved because you are living demonstration that now there is this opportunity for researchers in the space. But we have identified quite a few other hurdles, particularly in the regulatory environment. And actually, the words that we just heard from the four of you are very much encouraging. We just hope that at the EMA next week, we can have similar encouragement. So many of us will be participating and many of organizations will be making similar cases to regulators. But I would say it's not an achievement itself if we manage to convince the EMA next week. There is very much more to be done in terms of access, in terms of creating the enabling clinical environment to allow for this access of new therapeutic options for patients. So I'd like to thank everyone in the in presence, but also virtual audience today. and also take up the words that were expressed in order for us to be able to feed into the next mandate and continue our efforts. So thank you very much and enjoy the rest of the afternoon.